Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated.
Welcome to Family Medicine Grand Rounds, our month of May edition. My name is Doug Archibald, and I'm the Director of Research for the Department of Family Medicine. And I'll be today's moderator. And we have two great speakers this morning. First off, we'll hear from Dr. Kamila Premji, who is a family physician practicing at the Primrose Family Health Center here in Ottawa. She's an assistant professor with the University of Ottawa and holds the Faculty of Medicine Tier 2 Clinical Research Chair in Universal Access to Comprehensive Primary Care. She's also a PSI Early Career Knowledge Translation Fellow, and she recently completed her PhD in family medicine at Western University. Inspired by her practice, she's passionate about research examining primary care access, care continuity, and health systems integration. She'll be followed by Dr. Vikas Bhagirath, who's a rural family physician in Winchester. His focus is providing continuous and comprehensive primary medical care for individuals and families across all ages and stages of life. This includes preventative care, diagnosis and treatment of acute and chronic illnesses, and management of ongoing health needs, serving as the central point of patient care. So with that, I am now going to hand everything over to Kamila. Over to you.
Good morning, everybody, and thank you, Doug, for that introduction. I'm just going to share my screen here and then get it into presentation mode. Okay, is everybody able to see my slide there? Yeah, okay.
Just perfect. Yep.
Perfect, okay. So yeah, thank you again for joining this morning. The work I'd like to share with you today, I've titled From Attached to Unattached and Back Again. It's a multi-phase study that examines patterns in primary care transitions and the health system impacts of those transitions. So the first phase that I'll describe examines the temporal trends in gaining or losing enrollment in a primary care medical home in Ontario alongside policy changes. The second phase examines what happens at the system level when someone loses attachment, specifically looking at emergency room visits and health system costs. And the third phase examines what happens at the system level when someone gains attachment, what costs are incurred as patients catch up on things like missed or delayed care. Before I start, I just wanted to share this photo with you all. It's from a little hike I took a few weeks ago at the Cart Barrens Trail. If you haven't been, I strongly recommend it. It was my first time going there. So I took this hike and this photo on the traditional and unceded territory of the Anishinaabe Algonquin people. And I'd like to acknowledge that that's also the land from which I'm presenting this work to you today, although not, unfortunately, from the trail. As a settler, I'm very grateful for the continued care of this land by the Anishinaabe Algonquin people. And it's moments of awe like this one that I tried to capture in this photograph, where I'm confronted by the beauty of the landscape and feel that connection to it, that I find myself most keenly aware of the privilege I have to be here and the personal responsibility I and every other settler here has to care for this land and pay respect to its traditional guardians. I'd like to acknowledge my Rockstar co-investigator team here, as well as the Rockstar U Ottawa research staff who have helped with this study. We've also gleaned very helpful insights from system stakeholders who we engaged at the provincial and federal level to help develop the objectives of this work so that it would match the work that they need to do. And also we introduced patient partners to this study who are now part of our co-investigator team, and they are from PERC, an organization out of McMaster, and have been very helpful in shaping this work. I have no conflicts of interest to declare. So just to summarize the sequence that I plan to go through with you today. So I'll start with the background, so describing the context and the rationale for this study, and then get into the specific research questions. We are hoping to answer the methods that we're pursuing to do that, and then I'll share with you results from the first phase of the study, looking at temporal trends of adults gaining or losing enrollment in primary care medical homes in Ontario, and results of part of study phase 2, which is the health system impact of losing attachment, specifically looking at ED use, and then go into kind of the next steps that we plan to do and go over the key takeaways before opening things up for a conversation. But I won't spend too much time here. Everybody at this call knows that we're experiencing challenges in primary care attachment. Further workforce shortages are expected as family physicians retire and as interest in primary care among trainees remains lower than ideal. We know primary care access is important at both the individual level and the health system level. And over the last few decades, we've seen formal enrollment in a regular source of primary care or a medical home emerging as a key strategy in many high-income countries to strengthen population health. It confers accountability for a defined panel of patients and allows then for health surveillance and quality improvement at a health system level. But Canada lags in both formal attachment to primary care and overall attachment to primary care compared to peer countries. So confronted with these challenges, the Ontario government has introduced a number of policy responses. Most prominently, they've introduced the Primary Care Action Team, which is led by Dr. Jane Philpott. They've introduced a few rounds now of new funding for teams, interdisciplinary teams, either to expand or start new teams. They've increased training spots for primary care professionals. There's been an effort to target recruitment of medical students into medical schools who are specifically planning to pursue family medicine, and Queen's has a specific dedicated stream for those students now. And most recently, the Ontario Ministry of Health and the Ontario Medical Association received an arbitrated agreement that revised family physician payment. The overarching goal that has been stated by the government to achieve from all of these efforts is to attach all Ontarians to a primary care home by 2029. So what we're doing in our research is producing data to help guide policy development and health system planning as these initiatives play out, because we do expect to see ongoing fluctuations as this work is being done. We know there will be ongoing losses in primary care attachment, especially as the near retirement workforce exits the workforce, as well as hopefully gains in primary care attachment through the efforts that are being made at a policy level. So we want to help plan for the short to medium term consequences of these fluctuations in attachment. So our specific research questions are: what trends have we seen in Ontarians gaining or losing formal primary care attachment over time? We call this phase of the study phase 1, our trend study. The second question is, what health system impacts should we anticipate when a patient loses their primary care attachment? We call this part of the study phase 2, or our loss study, and we look at emergency department use and health system costs. And then we look, then our next question is to understand what resources are required to catch up on missed or delayed care after regaining attachment to primary care. And we call this phase of the study our gain study. So today what I'll be sharing with you, though, I will be focusing on the first study as well as the ED section of the second study. I won't spend too much time digging deep into the methods, but I just wanted to summarize them here. For the trends study, we conducted a retrospective cohort analysis, serial cohort analysis. The population of interest was all Ontario adults, and we looked at the proportion of adults gaining or losing enrollment in a patient enrollment model, a PEM model, over time. In the law study, we conducted a controlled before and after analysis. We looked at ED use in the 2 years after losing primary care attachment compared to ED use in the 2 years before losing attachment, and compared this change against the pattern of ED use among those who remained stably attached throughout our study period, in order to quantify the excess number of ED visits that result from loss of primary care attachment. So getting into the results now. So starting with the trends study, so temporal trends of adults gaining or losing enrollment in primary care medical homes. The first exhibit I want to share with you is this one here, where we look at the monthly gains and losses in enrollment over time. Our study period went from 2009 to 2021, and you can see the month and year along the x-axis there. And along the y-axis, we have the percentage of all Ontario adults who either gained enrollment in a patient enrollment model, that would be the orange line, or lost enrollment in a patient enrollment model, that would be the green line. And you can see that initially a larger proportion of the population was gaining rather than losing enrollment, but this gap narrowed over the study period. And this translated to a statistically significant decline in net changes in enrollment over time. The dotted line here represents the linear regression. The slope was negative and was statistically significant. To contextualize these results, here we're looking at Ontario adults enrolled in a patient enrollment model over time compared with population growth over time. Starting with the gray line here, which maps to which represents the number of Ontario adults with PEM enrollment. We see that grew over time. It maps to the y-axis on the right there. The orange line, if we look at the orange line, however, the overall population of adults also grew. This also maps to the y-axis on the right. And what we see then from the blue line, which maps to the y-axis on the left, is that the overall proportion of Ontario adults with enrollment increased until 2015 and then decreased. And this was despite growth in medical home physicians per capita outpacing population growth. So here we have PEM physicians represented by the green line, and this maps to the y-axis on the left, compared with the population of Ontario, which maps to the y-axis on the right. What we did next was out of interest, we looked at the timeline of all the policies introduced during our study period that impacted primary care positively or negatively, and superimposed those on the timeline of our net changes in enrollment over time. And what we saw, it was a sequence of policy changes that pretty much entirely negatively impacted the most popular primary care model among physicians, which was the capitation-based payment model, and that also negatively impacted the model that the research has shown physicians at all career stages are interested in being a part of, which is interdisciplinary teams. We also observed that people experience very long durations of unattachment after losing enrollment in their patient medical home. And this aligns with previous research from BC and the United States. We saw that losses in enrollment were mainly occurring in fee-for-service-based PEMs. We saw that compared with males and younger adults, females and older adults had higher rates of enrollment throughout the study period. And we saw persistent gaps in enrollment for equity-deserving populations throughout the study period. These populations were disproportionately affected by the declining enrollment rates. So going now into the second phase of our work, the loss study, here we look at ED use in the 2 years after losing primary care attachment compared to ED use in the 2 years before losing attachment, and compared this change against the pattern of ED use among those who remained stably attached throughout the study period. And for each stratified linear regression that I'll be presenting, we adjusted for all covariates, including sociodemographic characteristics, medical characteristics, and baseline healthcare utilization to the extent that we had data available in the ICS data sets. So I'll orient you to this graph, and then the next graphs are structured the same way. So you just have to learn how to interpret this one, and then you'll know how to interpret the remaining ones. What we're looking at here is the change in the number of ED visits per 1,000 persons after losing attachment, with our comparison group being, again, the stably attached. So in other words, excess ED visits among patients who lost attachment. And we present here the results for the overall population and the population stratified by characteristics like age or sex. The orange dot that you see represents the change in ED visits per 1,000 persons in that group of patients. So for example, males compared to the stably attached group, for example, stably attached males. And the vertical line represents 0, meaning no change in ED visits post-loss compared to those who remain stably attached. So anything to the right of the vertical line is an increase in ED visits post-loss compared to the stably attached counterparts of that group. And what we see looking first at the overall population is that after adjusting for covariates, those who lost their family doctor experienced an average increase of 26 additional ED visits per 1,000 persons compared to those who remained stably attached. We saw particularly marked increases in the number of ED visits for certain subgroups compared to their stably attached counterparts. So for example, this older set of patients had quite a higher number of excess ED visits. Rural patients, those with high levels of comorbidity, they had 238 excess visits per 1,000 persons. Those with a severe mental health diagnosis, they had 170 excess visits per 1,000 persons, and those with a substance use disorder. So they had 373 excess visits per 1,000 persons. So now we divide up the results by the type of ED visit. So here we're looking at the change in ED visits post-loss of attachment compared to the stably attached for the highest urgency ED visits based on their CTAS score. So the CTAS system, for anyone who's not familiar, assigns a score based on the urgency of the presentation of a patient who comes into the emergency department, and CTAS 1 or 2 would represent the highest urgency cases. So here we see that substance use disorders and severe mental health diagnoses are especially impacted, as are older age groups. When looking at moderate levels of urgency for an ED visit, we see more variation in the magnitude and direction of impact with those in rural communities, certain older populations, those with high levels of comorbidities, and those with mental health and addiction concerns being particularly affected. And finally, the type of ED visits that policymakers are most interested in, which is low urgency ED visits that are deemed potentially manageable in primary care instead. Here we see that almost every group is negatively impacted by losing attachment to primary care, especially those who are older, those in rural settings, those with comorbidities, and those, again, with mental health diagnoses, severe mental health diagnoses, or substance use disorders. And then this graph just places all the different CTAS groupings, urgency level groupings, on one chart. So you can see how they're impacted relative to one another. And you can see that CTAS 4, 5, the lowest urgency visits, which are the green dots, are more impacted. So through this work, we've quantified the number and urgency level of excess ED visits expected after patients lose primary care attachment, as well as the sociodemographic and health characteristics driving those excesses. And our hope is that this will enable health system planners to anticipate the resources that affected patients will need. So, for example, if you look at the patient panel characteristics, of a soon-to-depart family physician, somebody that you know is going to retire, or a group that you know is going to be retiring or closing practice. Health system planners can use our data to help understand how they need to resource local emergency departments. They may perhaps implement more targeted, less costly sources of care like mental health supports, and they may prioritize certain subgroups for attachment, like those in rural communities and those with high comorbidities, those with severe mental health disorders, and those with substance use disorders. And this will be especially practical in cases where there's a large number of patients who are expected to be unattached in a particular community. And we've seen that happen a couple of times over the last few years in Sault Ste. Marie, where 10,000 patients were unattached when a group of family physicians left their practices, and in Kingston, when 8,000 patients were unattached when a group of family physicians retired. So next steps, we plan to conduct a similar analysis that looks at the health system costs, stratified by health cost type for those who lose enrollment. And we also want to look at the GAIN study, and the GAIN study is actually our current focus. It's of especially high interest to policymakers who need to know the resources to plan for as people catch up on care, as their efforts to attach more patients unfold. And we're especially interested in looking at primary care costs, preventive care costs, specialist referrals, and tests. So to summarize, the results from phase one. So Ontario's patient enrollment model program hasn't achieved full population coverage, whereas other countries that have employed the medical home model, like Norway, Finland, Denmark, UK, have achieved near full coverage. And these other countries with near full coverage typically employ a salary-based model or blended capitation and have interprofessional teams. Policies that negatively impact the availability to physicians of capitation-based payment models and interdisciplinary teams in our study seem to coincide with declines in attachment rates, despite increases in the number of physicians per capita in medical homes. The introduction of the new FO Plus model, which is part of the arbitrated agreement I mentioned earlier, may help reverse this trend. And phase two, the key takeaway from my perspective there is that health system planners can use results to estimate the ED resources needed for predictable losses, prioritize attachment for certain areas, and prioritize attachment for certain subpopulations. So I'll stop there, and I'm not sure if we have time for questions or discussion.
We sure do. Absolutely, Kamila. Thank you very much. Great presentation. And I can see Bill's got his hand up right away, so I'll save my question for the end if we have time. Go ahead, Bill.
Hello, Kamila. Fabulous work. Great presentation. Thank you. In your next steps, you indicated that you were going to look at cost. And I think by that, you might mean dollars and cents. And I'm sure you're going to look at the cost per patient the cost per patient when a patient is unattached compared to attached. But I wonder if you've thought at all about also looking at the cost on the basis of the family doctor. I mean, there must be some estimate of what it costs the government whenever they increase the number of family doctors by one. And it would be interesting, I think, to look and then, how much it costs the society to create a family doctor and employ that family doctor. I'm sure it's over $1 million when you look at the costs of ordering tests and all the rest of it. And it would be just fascinating to me to know whether the government is saving money or losing money on the basis of the restricted number of family doctors. Just so it's just a different denominator rather than doing it by patient. I wondered if you'd thought of that.
Yeah, great idea. We hadn't thought of that actually, but I will bring this back to the group because I do agree with you that it's quite interesting. I think generally it's going to be cheaper not to provide care than to provide care. So I think that when people lose attachment, we may see a decline in certain types of costs. And of course, when we have people gain attachment, we expect that they will see an increase in costs, especially primary care costs. We're not really looking at costs as a negative or positive outcome. What we're looking to do is just inform planning. We don't think that it's very useful to try to apply a judgment to costs being higher or lower because um, it may be actually very appropriate for there to be higher costs in any of these scenarios. And it may be actually negative for the long term, longer than we can study in our study period to have lower costs from lower amounts of care. Um, so um, I think that you're right that the physician has a contribution to the cost, and I'll bring that back to our group. Thank you for that, Bill.
Claire, then Ben.
Thanks, Camille. I mean, so many things I want to say, right? I'll try and like tighten up my thoughts. Really excellent presentation of your results, or what I know can be sort of complex concepts to convey in a short period of time. And I have a few thoughts. One is, and I'm seeing some comments in the chat about like morale of family physicians, and there was that great article editorial in the Globe talking about, the fact that actually physicians, I don't think it specified family physicians in the article, but talking about like how much physicians earn in Canada compared to other settings, right? And actually, we do fairly well, even though we don't always feel like it, especially those of us who perhaps work in models where we don't give a huge amount of our gross overhead to um, our gross income to overhead, for example. And it makes me wonder, like I often say, I don't think I need more money, I need better working conditions. And I would be curious to know, as you're looking at those low acuity visits, if there's any way to disentangle it. I know it's tricky with the coding and things, but like which conditions or reasons for emergency department visits could have been addressed through another provider, right? Like if we can try and lump those, like screening, for example, is something that could actually be done. The vast majority could be done by a non-physician, or integrated care pathways, things like COPD, asthma, diabetes. All those things could actually probably be better managed by someone within it. And I think that's where we're struggling, right? Is still with our interprofessional model. So it's just sort of a thought I'm having. And then the other is really trying to think about how, as a department of family medicine, with the diversity of different sites, contexts, environments, we can think about addressing this in our community, right? So, as you said, a big practice closes. We have no impetus right now to pick up patients from closing practices. There is still definitely an approach to where groups, even with on this call, or most of the groups on this call are wary of the Healthcare Connect list, wary of taking highly complex patients. Again, and I think sometimes comes down to model, but if we can start to work together better, we could attack this from a regional perspective of care. I don't expect you to answer that question. It's just a comment and something that keeps me up at night.
Thanks, Claire. Yeah, I share your concerns about who is going to take over these patients as physicians retire or leave the workforce for other reasons when there's really not sufficient infrastructure to help do that. And I agree with you as well. It's the working conditions, not the money. I think the capitation-based models and the interprofessional teams indirectly address that. The capitation-based models allow you to have some breathing room and time to spend with your patients to do the work that you need to do. It enables you to do types of care outside of visits, knowing that you are being paid for that care, like, going through your preventive care list and contacting all your patients who need their flu shot or their HPV screening. And the interprofessional teams get at the point that you're making that other providers also play a role in our system and could be used more effectively. I really love your idea about the diagnostic codes. I think it might be complicated, but it's worth looking at what diagnostic codes are most common for those low urgency emergency department visits as a means for helping policymakers plan around those kinds of visits, targeting those kinds of visits. So thank you for that.
Ed, Arun, then Ben.
Ben or Arun first?
Oh, Arun, please. Yeah. I think Arun did. No,
I think Ben
who
was
had
in
their
front
hand
of
up
me.
first?
No, I thought Ben was in front of me.
Okay, go ahead, Ben.
Oh, thank you. This is fantastic, Kamila. One of the things that I've noted in our FO is that when we're dealing with older people, the expectation is that we're going to provide more visits. And so I always I'm starting to bristle more and more now when we start comparing physicians to population as opposed to physician to population need. And as the older physicians are retiring, usually they have older practices and older populations. And so a practice size of 1,000 with a heavy proportion of 65 and older people is very, very different than my suspicion of the average practice that the Ministry of Health is expecting, because that bell curve in these practices is no longer maintained. And so I wonder if there's a way to measure not the population like by head, but by service provided. Right. So that if you have because through the FO payment model, we have a sense of what the Ministry of Health is expecting in terms of visits, right? So an 85-year-old lady will get, I don't know, like 2 visits more than an 85-year-old man, and maybe 6 visits more than a 65-year-old. I'm making these numbers up because I don't remember. But all I do know is that in my practice, I have a heavy load of geriatrics, and my visit and my fees are matching some people in my FO who have a practice twice the size, right? So I'm saying it's not the panel size, it's not the people, it's the services required to service a practice. And
Yeah, 100%, Ben. I fully agree with you. And actually, we tackled this question in this article that I'll put up here, where we looked at the near retirement workforce as well as the entire workforce by career stage and the health characteristics of their patient panels. And, we confirmed exactly what you've observed, which is that the older near retirement physicians have older, more complicated patients who are going to need more resources compared to younger physicians with fewer comorbidities. So, I agree with you that that's also an important consideration. And I hope that that's being factored into policymakers' planning. We've certainly shared this work with them. And there seems to be some acknowledgement that yes, this is a problem. We have these trends colliding where the patients are getting older, the physicians are getting older, not enough people are coming into the workforce to absorb those complicated patients.
Yeah. And then the second point has to do with the equity issue that I saw with the emergency room visits and the CTASs 3 and 4. One of the things I think about is, when some of my people who are the working poor, the only time they can get seen is after hours because if they can't take time off. And so I think that in some people who have, lower socioeconomic or more socioeconomic challenges, I suspect that that's probably why they're using the emergency room more often, simply because that's the time they have available.
So yeah, we actually constructed our analyses to address that, Ben. So
Okay.
what you see in those graphs are that group compared to its stably attached counterparts. So people with substance use disorders who lost compared to people with substance use disorders who stayed stably attached. we're comparing those two and looking at the difference in the differences of AD visits pre and post, or post minus pre, to exactly address that, because we know certain groups are going to use resources more than other groups. We don't expect young healthy males to be using many resources, but we were interested in seeing, okay, well, how do those young healthy males compare to their young healthy male counterparts when they lose attachment? So that's how we've addressed that. And sorry, I should make that more clear in the slides, but that was exactly our concern as well. Thanks for flagging that.
Kamila, thank you so much. Great presentation, great discussion. Arun's just going to put his question in the chat, and now we're going to transition to our second presentation by Vikas Bhagirath. And while he is sharing his screen, just like to make 3 quick announcements, and there will be links put in the chat. One is from Zach Van Allen, advertisement for AI co-design, Trish Houston, a climate survey link, and Kira Delanjalal has a teaching in seconds survey. So if you have a chance to do these, please do. And over to you, Vikas. Thank you.
Great, thank you. It was a great talk, Dr. Premji, too. Thank you. Yeah, is everyone okay with the audio? See the screen okay? Thumbs up?
Perfect, Vikas. Absolutely.
So, thank you for the opportunity. So I am not really a researcher per se, so this is kind of new for me, but we did a study about AI scribes for family medicine residents. And it was a mixed method study with myself and Dr. Jolene DeLille and Dr. Jones Delcourt in Winchester. So I start with the land acknowledgement. So I'm here in Ottawa. It's a traditional unceded and unsurrendered territory of the Anishinaabe Algonquin people who continue to live here today. I'm making this acknowledgement just to honor their presence and express gratitude for being the traditional stewards of the land and serve as a visible step towards reconciliation. And, what have I done for reconciliation is I've tried, in Winchester, we tried to create a partnership with the Akwesasne First Nation. They're the Mohawk First Nation to have residents train there on the reserve. Now, the Mohawk and Algonquin are traditional rivals, but they tell me it's okay and it's all in the spirit of reconciliation. But that's my land acknowledgement. I also thank Dr. Jolene, who basically does a lot more research than I do, and she's been a great mentor and helped me get this done. And I'd also like to thank Ms. Lauren Langlois Lemay, who helped prepare these slides. So, just as we all know, detailed charting is more and more required. Like, gone are the days where you can scribble a quick note about your clinical encounter. It's now the expectation that there's a very good note medically, legally, and for continuative care. And that takes time away from doing other things such as seeing patients and other clinical things. So it creates this administrative overload. And now there are technologies that can help, that basically can generate your note. And how does this affect the residents when they're training them? And it can affect their learning and their reasoning. So we just wanted to explore this. So we wanted to basically check to see how it affected their productivity, workflow, and learning in the family medicine training program here in Winchester. So a lot of things came together to get us here today. So we take it for granted, but this is decades and decades of hard work and technology. So we're all familiar with the automatic speech recognition. That would be like Dragon or talking to Siri, where the sound waves is converted to text. That technology came with natural language processing. So essentially you can write stuff in English that would be coded, and then the code goes back to English. So you can actually ask questions and things to the computer using natural language. And then deep learning models, neural networks, tremendous speed can be used to get enormous data to spit out a report very fast. So all these kind of came together to make the AI scribes, which you know today. There's many products available, and there's more and more happening all the time. So that's kind of where the technology kind of came together to where we are now. So for our study, we used through the Prime grant, we used the AutoScribe, which is by Mutual Health, a Canadian company. They provided licenses for the duration of the trial, and we used it in our clinic. We wanted to assess, the basics like productivity, like how many patients were seen in the clinic without AI scribes, and then the notes themselves, how useful they were, and the editing burden required with them, and then what impact on the learning did the residents note with using the AI scribes. So again, for the methods, it was like a mixed methods of pilot study. We used like the clinical data, but then we also did semi-structured interviews after the study to get more information as well, which I'll talk about. So, basically every day the resident had a randomizer to use an AI scribe or not use an AI scribe, and that was randomized daily at the start of the day. And there were 7 residents in Winchester and over 126 clinic sessions in Winchester. The quantitative arm, that specifically just measured the number of patients they saw in the clinic with and without the scribe. And the qualitative arm was a semi-structured interview where we sat down with the resident after and asked specific questions after the study to kind of tease out more information. So the outcomes measured, for the quantitative arm, as I mentioned, is the number of patients seen per clinic session. And we also looked at some covariates. So like how many patients were booked in that clinic that day? Was it a full day versus a half day? How many providers were in the clinic? How many days since the start of the study? And what stage of training were the residents in? Just to see if there's any differences between those outcomes as well. And then for the qualitative arm, we used thematic analysis. So we do the interview and we transcribe the interview with the resident. And then we would kind of using some tools, well-researched tools, we would get themes from the data from the interview, and then those themes would be reviewed independently by 2 researchers, and then from that we would kind of refine those into 5 thematic domains. So the 5 things we kind of really focus on the semi-structured interview data was like the documentation quality and usability, the workflow efficiency, communication adaptations for AI capture, the effects on resident learning, and fit for context adaptation. So how likely were they to use the product in the future? So interesting. So for the quantitative arm, so again, through the 126 clinic sessions, as you can see, the patients seen per day wasn't a big difference between the AI scribe and the no AI scribe, which is what we found. The patients scheduled were similar for both of them, and full versus half days were similar. The number of providers were also similar. So they both had the AI and the non-AI session had similar scheduled patient volume and clinic structures. So the key finding, there was not a real difference between the number of patients seen with the AI scribe versus not the AI scribe. It certainly wasn't statistically significant when you combine them. Now, when we looked at it a little bit further, there was a bit of a difference between PGY1s and PGY2s, where the PGY2s may have seen more with the AI scribes than the PGY1s. But again, these are very small numbers to kind of really have any firm conclusions. There was a tremendous variability with the residents themselves too. So there are some residents who actually saw less patients with AI scribes and some who saw more. So I think it really depended on the person using the scribe, whether it helped their efficiency or it didn't help their efficiency. And so that was what we found on the quantitative arm. part. When we looked at the qualitative part, so that's a semi-structured interview, and the major themes identified again, they found the scribes useful, but they had a lot of nuance to it. For like, so, and we'll get into these in particular. Like for the note quality, they need to review the notes carefully, and that shifted the burden a bit. The workflow changed, like editing a note instead of writing a note. Communication, they found that they were more present, but they changed the way they actually spoke in the room a little bit. So in the learning part, they gain some focus, but then there's some concern about losing some of the skills that you would have been writing a note. And then most of them felt they would use it sometimes in the future. So specifically for note quality and usability, the experience is different a lot. There's some residents who really loved it and some who really hated the AI scribe experience. So, and I think that's true for most clinicians too. They often said that some of the nuance was missed. So like if the patient was very anxious about something, that would be missed in the note, or if they were, making a joke or something, that would be missed. And then there's a lot of editing burden. So after the encounter's done, you'd have to look at the note and kind of format it the way you like, or be sure that everything was appropriately written down. And then obviously, there's some things that they have to verbalize, like the physical exam. You couldn't just, the scribe would not pick that up. So as far as the efficiency, it kind of came across that things were redistributed. So instead of writing the note after, they'd have to edit the note after. So there's some efficiencies and some encounters, but then the review and correction sometimes would take a lot of time as well. And it was dependent on the resident and the encounter as well. So that was interesting to see. And then the communications, I said, they consistently said the eye contact was better with the patient because you're not looking at your keyboard as much. You're just kind of looking at the patient, knowing that all the details are being written down. So they like the engagement and the more patient presence, but it altered the speech. So if the patient's saying, in my, I got a rash here, then you'd have to say, oh, in your right shoulder. And if you say, oh, this knee hurts, the resident say, oh, your left knee hurts. And they sometimes have to say the physical exam. So it kind of affected the way they spoke to patients in ways. As far as the learning, they found that they liked the better focus with the patient encounter. There's more attention for the visit, but then you lose the skill of writing a note, which is a skill that's, just like any other skill, you have to learn and you have to do many notes to get a good concise note. So that skill could be lost if you're not writing notes anymore. So there's the concern about losing that. And then you have to understand that AI is not perfect, and you have to realize you have to edit the note, and sometimes it gets it wrong, or it kind of misses something completely. So they have to just understand that AI is not perfect, and they need supervision. As far as will they use it in the future? Most of them felt it's inevitable that they'll be used, in most times, but they find it is better to use selectively. So they've consistently said it was helpful for mental health visits or many complaints, but then it was maybe not as helpful for a prenatal or a very structured, focused assessment where maybe a stamp would be more efficient. But over time, as they kind of got all the nuances with the software, they seem to like it more in general. That came across during the interviews as well. But so some of the takeaways that we got in this small study was that there was actually no real productivity gain, which I guess we thought we would see, but there was no real increase in the number of patients seen. And there's a lot of editing burden, so some of the residents would spend longer editing the note than just writing the note themselves. So it would depend on the resident and the encounter. Um, and then, the learning part, it needs supervision, and you have to use it selectively, and you want to be careful that you don't completely lose a skill of writing a note as well, because some patients do not consent to using the AI scribe, for example, or sometimes it's not amenable to that. So you have to really think about how to implement it in a residency program. So I think it's best seen as like a workflow, a learning tool, but not just an efficiency tool, which is what it's marketed as in our study, anyways. Um, Before I get to questions, I just Dr. Dolan wanted me to put this up too, just a reminder of she made these AI videos, and she was just, if you were interested in seeing her videos and doing the survey, you can have a look at that at her study, which is really good. Um, yeah. So any questions there for me?
Vikas, thank you so much. That's just amazing. Great, very informative. Thank you very much. Move right to questions. I've got one, but I'll hold it off here. Arun, go ahead, and then Jason.
Thank you. Thanks, Vikas. Great presentation. Really like the topic matter, and also the where you conducted the work. I had maybe I missed this at the beginning, but it would be really good to understand the duration of time that people had to work with the tool, really how long your study ran for, and were there changes also, right? Because when we think about these tools, they're not static. They are very dynamic and they continue to change in a very aggressive fashion. So even like when we think about a study that might be 2 months, the tool itself might change in that 2 months. So just wondered if you could comment on that.
Yes, absolutely. So yeah, it was over 6 months, and that was the Winchester had doesn't have a block-based model, so over a longitudinal model. So that we thought that would be enough time to have enough clinical visits. But they certainly did find that over time they became more familiar with the technology. Um, and yes, the technology is changing. So this was done last year, and now the notes are, you know, the notes get better too with every iteration, or they get with the feedback from the people using it.
Excellent. And what a couple of other points that I wanted to make was, for me, I'm really interested around that patient provider relationship piece, right? So, I know that there was more presence. That was one of the themes that you identified, but it'd be interesting, or I'm not sure if in the theme development, were there other elements that we saw? Did we see there being a better formation of a relationship, maybe stronger attachment, not necessarily in the way that Kamila defines it, but an attachment between the provider and the patient? Were there comments towards that end?
Yeah, so I think fairly consistently they've felt that when they're writing the notes, they'd have to be constantly like jotting down, all the issues just so they can remember the details. But when they had that off, they could just literally just look at the patient more and be more engaged with the patient. So that did come across, and some of the patients also noted that they felt that they were being listened to more. Um, but, but yeah, so they did note that.
So I'm going to tie it off, and maybe this will relate back to some of the other comments that have been made. I have concerns about looking at productivity, especially as number of patients seen. I think, I think systems are going to want to see that, but I have concerns around that area. I think if as a group, as a field, if we focus more on how this strengthens the relationship with our patients and improves that relationship and that connection, I think there's something much more valuable there than just looking at numbers. How many more people have I seen? Because I think that's also going to benefit the patient, but it's also going to benefit us as providers. I think having those better relationships will make our careers that much more fulfilling. And so looking into that domain and that space and really unpacking it, I think will be very helpful for all of us to understand that, but also for our system funders to also recognize the importance of that beyond just have you seen more patients?
Exactly, and it is interesting. It didn't really pan out that way, and as far as like just satisfaction with the work too, I think I don't know if you probably noticed it too, if for those who use AI scribes, but it's very dependent on the person. There's some people who they do not like the scribes. They don't like the way the note works, and it's not going to be for them. So it's interesting. It's not for everyone. But the ones who do use it and like it, they do find that they have better job satisfaction when they use it. But it's not like it's not for everyone, which is interesting.
Jason, go ahead.
Hi, Vikas. It's Jason here. Great presentation. I think this is kind of building into a lot of the research that's coming out independent from us about the use of AI scribes with even staff. To kind of riff on what Arun was saying, I think that the metrics definitely are not. We haven't decided on what the right metrics are. Hospitals and I guess public health would want us to see more patients, right? That would be good for everybody, but that's not really our need. And I think what you're seeing with adoption is that this was an AI solution looking for that found a problem, and I'm not sure if the note-taking part of our paperwork burden is our problem. I know it's very easy to kind of make that jump, but I would talk about the inboxology being probably a lot more of an issue than this part. And I think that's what you're seeing with the adoption, and what we're seeing with the adoption when we kind of did the AI scribe pilot. So I think it's a good case study for like an AI solution trying to find a problem versus us having a problem and maybe having an AI solution to kind of tackle said problem. The other thing is I just wanted to talk about this concept really needs to be underlined of never skilling and de-skilling. This cognitive debt that we're going in is really serious, and as a department we have to make a decision on what we feel comfortable residents and ourselves losing as skills. There's a really now a heavily quoted study with endoscopy. They gave them an AI kind of assisted device to have them identify polyps. They saw that they didn't see more polyps with the AI assisted device, but when they compared pre and post, they saw that they were unable to kind of detect polyps as easily, meaning that there was a deficit that by using these tools, we have to accept that will happen. And I think that's huge for our residents at this part. Making note is formative. It's part of their learning. It's having them kind of really percolate what's important, what's not. This is a skill. And I think what your study's showing is that there's a lot of risk and there's not too much benefit to be gained. So some comments there. Sorry, Vikas.
Yeah, it's certainly not cut and dry. There's advantages and disadvantages for sure, but I personally use AI scribes and I can't imagine going back, but it's not, but you're right. I don't think my notes are going to be as good now than they were before I started using them.
Vic, can I ask a question? Just to ask a little bit more about the editing friction, where changes and corrections were made, but they didn't stick. And that's concerning. Any more about that?
Yeah, so I think as the technology gets better, it's going to be more personalized. And so the technology we used was literally from a year ago. And, I think the technology, learning how you like your notes, but I think just I just find that there's some people who really want this paragraph to be like this, next paragraph, they really they like their notes to be just right. And they're just not going to be happy giving up that control of that part. And there's some people like myself who, as long as I don't have to write the note, I don't really mind if the formatting is off or whatever. So it really comes down to what, some personal preference as well. But there's some residents who's spending a lot of time just editing, little things like the paragraph should be spaced more or things like that, whereas others would literally spend 10 seconds looking at the note.
Okay, so that's really what it was. It wasn't over like an error that was made. They fixed the error.
There's
and then
some,
it didn't, yeah. Okay.
Yeah, sometimes they'd get like the name of a medication wrong or something just like that. But often it was just like formatting and things like that too. So,
thank you. Leah, go ahead. Leah? Yep,
Hi, can you hear me?
Yep.
Hi, I wrote this in the chat, but I'll just spit it out. I have to say I agree with Jason that we were literally talking about this yesterday. I'm thinking about this like never skilling kind of cognitive debt stuff. did you get any information about which residents liked it and which ones didn't, and sort of other characteristics about them? So I'm wondering around like their confidence, like how are they with confidence surveys, or how are they doing academically? Like, are they strong academically or weaker academically? Like this kind of thing. Just sort of like I'm thinking around like understanding your blind spots perspective.
It's a good question. I mean, there's only like 7 residents, so I don't think I can make any firm conclusions about that. Um, I mean, the ones that really didn't like it, they were still very strong residents. Um, and maybe they were more of like a perfectionist mentality with the notes. But I don't think I can really make a conclusion about like confidence surveys and things like that. But that's an interesting question.
Thank you very much. I can see we're at time, everyone. So a big thank you to Kamila and Vic for your presentations. Great discussions here, folks. Terrific rounds. Thank you. Please do tune in next month. And also, if you can complete your session evaluations, that would be fabulous. All right. With that, see you later. Have a great day.